Hello, my name is Tanya Gottlieb, and I am the VP Scientific Affairs at MeMed. Thank you to the 9th Annual International C. diff Conference and Health Expo for the opportunity to present the results of the Observer study. The Observer study was supported by the European Commission under Horizon 2020 SME 2215, grant number 684589, and also by MeMed. I'm presenting this study, the Observer study, on behalf of the 3 participating clinical sites, which were the Carmel Medical Center, which is in Haifa, Israel, the Rabin Medical Center, which is in Petah Tikva, Israel, and the Rambam Healthcare Campus, which is also in Haifa, Israel. I'd like to thank everybody involved, the PIs, and especially the patients. The topic of this poster is a rapidly measurable host assay comprising TRAIL, IP10, and CRP has potential to reduce antibiotic overuse without increasing underuse in adults with suspected lower respiratory tract infection, LRTI. The background to this study is that identifying infectious disease etiology is oftentimes challenging, yet essential for appropriate patient management, including appropriate antibiotic use, as I'm sure everyone here in the audience is aware. Studies have shown that a host assay comprising TNF-related apoptosis-induced ligand, which is called TRAIL, interferon gamma-induced protein 10, which is IP10, and C-reactive protein, CRP, accurately differentiates bacterial from viral infections with negative predictive value of over 98%. So that is the background for this study. Just so you know, the TRAIL and IP10 proteins are actually induced in viral infections, and classically the C-reactive protein is induced in bacterial infections. But the TRAIL protein actually has quite an unusual behavior in that it goes up in viral infections and down in bacterial infections. And it's the combination of these 3 proteins, the computational integration of their measurements, that is the basis for this host assay. And in this study, the Observer study, and in the data that I'm presenting to you now, we estimate the potential impact of this host assay to complement current practice for adults with suspected lower respiratory tract infection. So for the Observer study, adults aged over 18 years with suspected LRTI infection were prospectively recruited at the 3 medical sites that I mentioned at the beginning. Infection etiology was adjudicated by 3 independent experts based on clinical, laboratory, microbiological, radiological, and follow-up data. So it was the adjudication of these 3 experts that was used to build a reference standard etiological label. The host assay was performed retrospectively, and it gives 3 possible outcomes based on predefined thresholds. It can give a viral result, bacterial, or an equivocal result. Assay performance and expert adjudication were blinded to one another. So to estimate the assay's possible impact on antibiotic use, as the Observer study was an observational study, the test result was not given to the physicians. So to estimate the assay's possible impact, the treatment documented in the medical record was considered the current practice, and it was assumed that a timely contraindicative assay result would have triggered a change in practice, which we call the current practice plus the host assay, with the current practice occurring in cases of equivocal results. So it was this model that was used to extrapolate the potential of this host assay, if it was available, to support appropriate antibiotic use. So the results: out of 583 adults recruited, 422 met the inclusion criteria for an infection. Of these, 314 were assigned etiological labels. Of those, 210 were viral and 104 were bacterial infections. So those are the reference standard labels. Patients with bacterial infections were older. They had a mean age of 61 years versus 51 years. for the viral infections. They had higher fever with a mean temperature of 39 degrees as compared to the viral infections that had 38.6, and were more likely to be admitted to the hospital. So 77% of the bacterial infections were admitted, in contrast to 31% of the viral infections. So then we applied this modeling analysis that I described to you of an extrapolation, and based on the discrepancy between the physician's prescription and the assay results, the host assay has potential to reduce antibiotic prescription to virally infected patients, virally as defined by the reference standard, by threefold. That's with a significance of a p-value of less than 0.001. So what it is doing is reducing the amount of antibiotics prescription to viral patients from 55.7% down to 18.6%. And it's doing this without having any significant impact on missing bacterial infections. So it's not causing underuse. So our conclusion from this, from these data, from the observer study and this extrapolation that I've described to you, is that timely provision of this host assay result, the host assay based on trail IP10 and CRP, has potential to complement current practice and contribute to improved antibiotic stewardship practices. So one aspect of being able to impact prudent antibiotic use is having a test that allows you to make a decision on whether it's a bacterial or viral infection, but also on being able to perform that test when and where you need it. And it's with this goal in mind that MeMed has developed a platform for measuring the host assay based on these three proteins, trail IP10 and CRP, that provides a result in 15 minutes from serum. So this host assay is now called the BV test for bacterial viral tests, and the platform is called Key, and both were FDA cleared a few weeks ago. And you can find out more about those on our the link for the webpage in the CDF conference. So thank you very much for all of you for listening, and I hope you find us and look up more about this important bacterial viral test.